Oh, you're okay. Tough act to follow. All right, I said you're a tough act to follow. All right, so we'll try to make this fairly quick, but there is a lot of content to cover. So we're going to go over neurological medical emergencies. And the first topic is stroke. So we're going to cover different types of strokes and also seizures, but most of the content is stroke. So these are just some statistics about how stroke affect everybody. So as of 2014, it was the 5th leading cause of death. It kills 130,000 Americans, so it's one every 4 minutes. It affects 795,000 Americans every year, and it's the most widespread and costly health problem in the U.S. And it's also the leading cause of disability in the U.S. among adults. So this is just some background on different kinds of stroke care, especially in the state of New Jersey. So back in 2004, they kind of wanted to streamline the different types of stroke care and increase accessibility for like the best practice for stroke care in all the hospitals in New Jersey. So there are 3 different types of centers. I don't know if I can use this. There we go. So there's comprehensive, primary, and acute. So Cooper is a comprehensive stroke center. We were primary, but in 2017, we were designated as the comprehensive stroke center. This slide just kind of goes through what primary stroke centers offer to patients. So we're not going to really go over that. So this is a comprehensive stroke center, what they offer to patients, and this is everything that we have here. Like I said, so it just says when you call a stroke alert that the team is down at the bedside within 15 minutes for assessment. There's the surgical team. There's a radiologist, all this kind of stuff. There's medical students. They do a lot of research on strokes. All right. So stroke treatment. Again, we're comprehensive, so we'll just go through the comprehensive stuff. We can administer TPA, or we also can do mechanical thrombectomy. We'll go over this stuff in more detail. All right, so there's 2 types of strokes, ischemic and hemorrhagic. So ischemic is when there is blood flow cut off in the brain and it's affecting the tissue, and then hemorrhagic is when there is a bleed in the brain. So ischemic strokes accounts for 85% of all strokes the patients experience. Again, it's when there is an obstruction in the blood vessel causing ischemia. Eventually, it will lead to brain tissue death. So time is of the essence when you're dealing with strokes. 2 causes of ischemic stroke specifically are thrombosis or embolism. So does anyone know the difference between thrombosis and an embolism? One is moving. Embolism moves. Go to the next slide. So thrombosis is basically formed from kind of cholesterol or atherosclerotic plaques in an artery. It causes brain tissue ischemia because it blocks the blood flow along the affected vessel. So the primary risk is just if you have a history of it. And then an embolism is an occlusion of the artery from a blood clot, any kind of infectious particle, an air fat embolism or tumor fragment. So like anything that breaks off from another part of the body that can travel to the brain and cause this obstruction. So the risks are listed here. Everyone knows, or most people know, with AFib, you're at risk for blood clots. Again, that can travel to the brain. Any kind of valve disease, cardiomyopathy, atherosclerosis, and endocarditis. A lot of our population here has a history of substance abuse and heavy drug use. So this is endocarditis. Have the septic emboli in the heart, which can travel to the brain. TIA. It's a type of ischemic stroke. The symptoms and the deficits last for less than 24 hours. There's no way really to diagnose it. If you do a CAT scan or something, it won't show an infarct on the CAT scan. So a lot of it is just symptomatically diagnosing a TIA. There is no permanent damage, but patients are at risk for having an actual stroke. And the way that we treat them, or if we decide to admit them, observe them, is based on a risk stratification tool. the ABCD2 score. We'll go over that with the next slide. So 30% of patients who have a TIA will have a stroke within 5 years. So that's why it's important to provide patients with education and strict follow-up. So this is the ABCD2 risk stratification tool. So if they're older than 60 years, if their blood pressure is greater than 140/90, clinical features of the TIA is weakness, speech, the duration of the TIA symptoms, if it was longer than 60 minutes. And then if they are diabetic, that's like the second D. That's what it just looks like, D squared. And then based on their score is this chart is kind of how they were treated. So if we keep them in the hospital, we just discharge them with strict follow-up. Sorry, I didn't make these slides. Most of these slides. So we're going to go over the hemorrhagic stroke, and then we'll talk about treatment for both types of stroke. So we said ischemic was 85% of most strokes, so hemorrhagic makes up 15%. There's a rupture of any kind of vessels that leads to blood in the brain or the surrounding tissue. It can be subarachnoid or intracerebral. All right, so subarachnoid hemorrhage is not when the blood is actually in the brain, but it's in the subarachnoid space around the brain. And when that blood accumulates, it puts pressure onto the brain, right? Because the skull really doesn't have much room for movement because it's bone. So all that pressure will push on the brain and cause these neurological deficits. The clinical presentation, patients will describe it as the worst headache of their life. It's usually sudden onset, and sometimes their mental status will kind of fluctuate, so they might be totally with it, and then they'll get confused, and then they'll be with it again. One of the most famous stories that maybe you guys have heard for a subarachnoid is, I don't remember her name, but she was like a famous actor that was skiing, and she didn't wear a helmet, and she fell, and kept telling her to go to the hospital, and she never did, and then she ended up dying from the subarachnoid hemorrhage.
I forget. Liam Neeson's wife. The actress.
Okay.
Yeah.
So, I mean, this happens to a lot of people, but these are just the stories that you'll hear about on the news.
Natasha Richardson, she died, a couple days later.
So this is the other kind of hemorrhagic stroke, is the intracerebral hemorrhage, where you actually have blood inside the brain. So it leaks into the brain. It can cause compression due to the added fluid, and like we said, the skull cannot expand. There are different types of causes for it, but hypertension is the most common. Drug use, too much anticoagulation, AV malformations, and then again, the clinical presentation is you're going to have these sudden onset of neurological deficits, headache, nausea, vomiting. All of these symptoms are something that you want to think about when anybody has increased ICP. So stroke symptoms, they're all listed here. Has anybody taken care of a stroke patient yet? Yeah. All right. So you guys are probably familiar with a lot of them. So a lot of times the stroke is just on one side. So the symptoms are going to be on the opposite side where the stroke is occurring in the brain. So it's unilateral weakness, unilateral sensory changes. Sometimes there can be vision changes or vision loss. There's speech changes. A lot of times it's slurred or they're having difficulty getting their words out. Headache. They're unable to walk because of that one-sided weakness. Facial drooping or asymmetry when they smile. And then difficulty swallowing. These are all the things you're going to do on your assessment on the patient when you're taking care of the patient. So this is just some information about the brain and what's going on while the stroke is occurring. So the core area of the brain where the actual stroke is occurring, those brain cells die very quickly. The penumbra is outside of the core, and that area of brain cell can be recovered as long as you intervene quickly enough. This is just some anatomy review of different parts of the brain and what functions they're responsible for. So, for example, if you have a terrible bleed in, let's say, if you have a terrible bleed in the brainstem, right? It's affecting their breathing, their heartbeat. The patient's probably going to be a lot more sick. You might have to intubate them. You're going to see changes on the cardiac monitor. So this is just the motory versus sensory, and it's kind of just a diagram of the vasculature. So depending on where, if it was ischemic, depending on where the clot was, again, would tell you kind of where the infarct was. So even though we have CAT scans and everything now to tell us where the injury is, if you can assess your patient very clearly and pinpoint where their symptoms are, you can correlate that to the area of their stroke. And then you can also tell if it's motory versus sensory, again, with the cranial nerves, which ones are motory, which ones are sensory, and which ones are both, based on the symptoms they're having. Visual deficits, they'll see the doctors a lot of times do cardinal gaze, they'll do peripheral vision checks, and we can do that as well with our assessments. All right, so stroke treatment. Early identification is best because time is your brain tissue and your brain function. So outside of the hospital, you're just going to call 911 immediately. Inside of the hospital, you're going to notify the doctors and they'll do a stroke alert, depending on the patient's symptoms. In the ER, it's a little different. It depends on, how long these patients have had these symptoms. If it's something new, maybe this patient just has bad luck. They're already in the hospital and now they're having a stroke. Or I guess it's good luck, right? If they're in the hospital and they can get the treatment. Then same thing, we would call a stroke alert. So this is the information for Cooper's stroke alert and how to call a stroke alert. Our time frames are listed here. This is probably hanging everywhere in your unit since everybody here works in a critical care unit. The doctors typically will call the stroke alert pager, but you are also allowed to do that. So there's always a neuro resident that's covering specifically the stroke team that will come to the bedside for all this stuff. And then here's our time frames. It's kind of unclear to see this, but maybe when it's printed you can see it a little bit better. The next slide we'll go over timing. So again, when you call that stroke pager, a physician will be at the bedside in less than 15 minutes. They're really good at coming on time. They're usually there in like 5 minutes. So they can do the initial evaluation, and then we can get like the CAT scans and everything. So the physician evaluates, the stroke team comes, they get their imaging and their labs. The labs are always drawn superstat by, or they're always resulted superstat by the lab so that we can get those results. Within 45 minutes, they want they want the labs interpreted. Again, it's always quicker than that. And then if the patient is eligible for TPA administration, it should be administered within 60 minutes of their time of arrival. And then if they need a thrombectomy, they should be on the table in the IR suite within 90 minutes of arrival. And all these numbers are based on, like we said, we're a comprehensive stroke center. All these numbers meet that criteria. So if they are new stroke symptoms when they're on your unit, or if they're coming into the ER, you want to know the last time they were known well. So when were they functioning normally? They had 0 deficits. They were at their baseline, because that is going to determine if we can intervene with TPA if it's an ischemic stroke. TPA is only given for patients with ischemic stroke. It's a clot busting medication. We'll talk about that in the next couple slides. So again, the last time they were known normal, it determines their ability for the treatment. Whose job is it to ask, and who do you ask? What do you guys think when they were last known normal? How are you going to find out this information if the patient maybe can't communicate with you? The family. What if there's no family? It could be a roommate, yeah. Anyone that lives in there. Yeah. So really anywhere you can get information from. We had a lady last week that she was really cute. She was like 90 years old, but she was very independent. She was out shopping on her own. So she was able to tell us that, but she couldn't really communicate clearly. So we went through her cell phone and her purse. We looked if there were any receipts because she told us she was shopping at Dollar General when it happened. The doctor actually called the dollar store to see, like, did you guys call the ambulance? What time did you call? So anytime you can get information, and anyone that you can get it from in like a timely manner is very important. I don't really know what wake up strokes means. I guess it means if the patient is, woke up from sleeping and now they're having symptoms. It's kind of hard to determine when they were last known normal unless you know exactly what time they went to bed. All right. So treatment timing. Again, this is for TPA and thrombectomy. So TPA is the clot busting medication. It's typically given if the patient has was last known normal within 0 to 3 hours from their arrival to the hospital. It can be given up to 4.5 hours, but that depends on like the risk versus the benefit, and that's usually up to the physicians and the family members. Well, if the physicians recommend it and the family members want to give it. So neuro intervention would be if they have to go to IR. They have to go to IR and they have to get the thrombectomy. It's within 6 to 8 hours. They should be on the table to get that done. So these are just the core measures for any patient that was treated for a stroke.
So a quick question about TPA. If for some reason we can't get TPA, is there anything else that we could give plus apply for?
No. So unfortunately, they fall out of that window depending on how critically ill they are. They usually stay for observation, and they will, if they're critical, they'll go into the ICU. Maybe if they need to be intubated, and then they kind of go from there. If they're not super critical and they're still breathing on their own, they can sort of communicate, not really. They'll just get admitted to Pavilion 7, which is the stroke floor. They'll have a speech consult, a physical therapy consult, rehab, that kind of stuff, just for kind of symptomatic management of how they're going to be able to function after the stroke. That's why we said all the way back in the beginning, it's like the #1 cause of adult disability, because a lot of these people we can't intervene for. There's a ton of information after this on TPA, which we'll talk about. So New Jersey stroke performance measures, these are just all things that are proven to be best care for stroke patients that we offer to all these patients, and that they have to be completed and documented before the patient's discharged. It just basically that they got the best treatment, and they have the information for follow-up, that they're on specific medications for follow-up, usually discharged on some kind of statin, on aspirin if they're not already taking it, that they were screened and they're safe to eat, stroke education, if they need to go to rehab, smoking cessation. Again, all these are risk factors for stroke, so we're just kind of educating the patient and their family members. So this is the stroke scale, the NIHSS stroke scale. Did all of you guys do your training for the year? Because we're a comprehensive stroke center, you have to do it every single year with the videos that are really unclear, but still important. So just the assessment tool that's used, all the physicians use it, all of the New Jersey hospitals use it. I think it's like the national standard for your stroke assessment. Once you do the assessment, it gives you a number. So it's a quantitative measure. It can help predict the size of the lesion based on like how severe the patient's symptoms are. It can help predict short and long-term outcomes. And then, like we said, for the severity of the stroke and the prediction of the lesion size, these are the numbers. Who can perform this assessment? We can. Yep. So probably in the ICU for all the ICU nurses. You guys will probably perform the NIHSS assessment, probably more than the ER nurses. We do perform them, but a lot of times there's so many people in the room, all the neurologists are in the room, they're the ones that are really performing this. We do, of course, we'll do the frequent neuro checks afterwards, but the neuro team is down there all the time.
How often do we document this?
There is a protocol for after TPA administration. We'll go over it in a couple minutes, but usually it's if they're admitted to the ICU every hour. But vital signs, there is a whole different protocol. So it's more frequently than every hour. Yeah. All right, so TPA administration. Your floor should have a pharmacist that will bring you the appropriate dose of your TPA, but it's weight-based, so it's 0.9 milligrams per kilogram, but the maximum dose is 90 milligrams. So if you have like a really, really, really heavy patient, they'll just get the 90 milligrams. Everything invasive has to be done before you give the TPA because now they're at risk for bleeding. So you need 2 peripheral sites, if not more, before you give the TPA because you're, again, at risk for bleeding. Your baseline labs were already sent when the stroke alert was called. You give 10% of the dose over 1 minute, just IV push. The neuro doctors are responsible for pushing that. You will never, ever, ever give that bolus dose. So make sure they're at the bedside with you. And then after that, you give 90% of the rest of the dose through the IV over 1 hour. And then that gets flushed with 50 cc's of normal saline. That runs at the exact same rate as your continuous dose. When you are setting your pump, you have to actually set the volume to be infused a little bit less than your continuous TPA dose because you don't want to dry out your IV tubing because you still have to flush it with the 50 cc's of normal saline. So you always, like, for example, say if your dose of TPA is, I don't know, 50 milliliters, set it for maybe like 35 so you don't dry out that tubing. And then just keep going back in. Obviously, it'll beep at that time. If there's a lot left, then you can change your volume. But again, you don't want to dry out that tubing because the 50 cc normal saline is it's a bag that you have to spike. So you want all of that TPA that's still in your IV tubing to get to that patient. If not, you're going to have to reprime it, and then they're losing part of that dose. Does that make sense? So these are contraindications for giving TPA. You can read through them. I don't want to read off the slide for you, but basically anyone that is at an increased risk for bleeding, we don't want to give this to them. And anyone that has a hemorrhagic stroke, we are not giving it to them. There's something listed here about elevated blood pressure. A lot of times we will, if they're a candidate for TPA, we will treat their blood pressure before giving the TPA with IV blood pressure medications, whether it's just a couple push doses or if they're going to be started on a blood pressure drip, we'll treat that because if they can have better outcomes with TPA, it's better to treat the blood pressure and give them the TPA. I also was reading online, I don't know if it's on these slides, if, say you have a stroke, you're given TPA, and like 5 years later you have another stroke, you can't get TPA again. It's only once in your lifetime that you can get a TPA dose. I don't know the rationale behind it. These are more contraindications. Again, just anticoagulation. If your platelet count is too low. All right, so here's the nursing care. This is really what's important for us to know. Nursing care after TPA administration. You want to monitor this patient for any signs of bleeding. Now that we've given them this medication that's going to increase their risk. So common sites, I think I have it listed here. So common sites for bleeding that you might see are gums, hematuria, hemoptysis. I don't know if this is on your, I don't think this is in next slides. I don't know if it will be on the test, but it's important to know. IV insertion sites, skin hematomas, or bruising. So a couple weeks ago, I TPA'd a patient, and his gums were bleeding just like so much you could really barely even notice it. It's almost like when you floss your teeth, and like you just have a little bit of blood there. So I called the neuro resident just to be safe, and they say turn it off. And I also talked to ICU. They're like, that's crazy. We can just give them something local to stop that bleeding. But they, better safe than sorry. So we stopped the TPA and we CAT scanned the patient, and he actually had a bleed in his brain from the TPA. So it's like, yeah. So it's really important that you're frequently assessing these patients and the common bleeding sites. And then my little old lady that was shopping, she just developed like some hematomas on her arm, on her lip. It's not like she had like fallen or hit herself. She was just laying in the bed and she developed these. So it's really important to do these frequent assessments, especially again at the most common sites. So here are your neuro assessments and your vital signs. If you have a stroke patient, it's part of an order set that the doctors put in. So if you ever have any questions, just go right into the orders and click it, and it'll tell you exactly how frequently you have to do everything. So neuro assessments and vital signs. For the first 2 hours after TPA administration, you have to do everything every 15 minutes. After that, it's every 30 minutes for 6 hours, and then it's every hour for 16 hours. So it's any signs and symptoms of bleeding, any improvements, any from the TPA administration, any worsening symptoms after TPA administration. So that's why it's really important, again, to do these. And sometimes people will get worse and then they'll get better, or sometimes they'll kind of go up and down. So that's why, again, very important. Do they get what? Oh, you mean in the ICU?
Yeah.
I don't know. Tom, do you know the answer to that? If you have a person that was post TPA in the ICU, what's the nurse to patient ratio?
Honestly, I do not know, but we can find out.
I know, yeah.
I was just a couple weeks ago, you told me it was 1-to-1.
Well, in the ER, guess what? It's not 1-to-1. I don't know about the ICU, and we'll find out for you. In the ER, it's probably like 1-to-4. But those people are the most sick ones, so those are the ones that, you have to really get in there and assess. And you can also tell, all your other nurses, whatever unit you're working on. Sometimes you get busy and you're pulled into another room, or even if you're just helping another nurse and they're your only patient, just, keep an eye out on this patient because they were stroke and we give them TPA if you notice anything different. So, again, my little old lady was totally fine, and I was sitting there teaching a student, and one of the other nurses noticed that she was like taking her gown off, and she wasn't doing anything like that before. So that's actually when we did like another CAT scan of her head just to make sure she was okay. So I don't know the ratio, but just make sure you're doing assessments and looking out for your peers and your patients. So after you give TPA, and even before actually, you really want to manage the patient's blood pressure. So the goal is that it's less than, the systolic is less than 185 and the diastolic is less than 105. You can give blood pressure medication, again, to control that after you give it. But you obviously don't want it too high because now you're at an increased risk of bleeding. We don't really see these patients in the ER, but for 24 hours after, we do see this, I'm sorry. So 24 hours post TPA administration, you don't want to give any additional blood thinning medications. You want to avoid any central IV sticks. That's why it's important to put all your extra peripheral IVs in before you give the TPA. I don't know what this means. Avoid non-compressible sites for IVs. Oh, I guess, I don't know. If like, again, central lines, they're kind of hard to compress against a central line. And then MPO for 24 hours. This is really important. We've been having some fallouts with the stroke stuff for the MPO. So this kind of relates to ER and ICU. So sometimes we're so busy with all this really rapid treatment in the ER that we don't have time to do the swallow evaluation on them. And obviously you don't want to falsely document that you did a swallow evaluation on them. So as long as the patient remains MPO for 24 hours, that's fine. You don't have to do the swallow evaluation until 24 hours. However, if there's something documented in the chart that they got an oral medication, or that you fed them breakfast, or that you fed them lunch, after TPA has been given within 24 hours, that's considered a fallout. So even if the patient looks fine, don't even do the swallow evaluation on them until 24 hours. Unless it was done before we gave TPA. Does that make sense? There were some questions with that when I was talking to a bunch of people. So just document in your notes that they remain NPO if you don't do a swallow evaluation before TPA. So this is after a neurointerventional procedure. Again, if they had the thrombectomy in IR. So you want to check the lower extremities, do all of your neurovascular checks in your extremities. You're going to do frequent vital signs, which you're already going to have them on the monitor anyway, and a lot of them will probably have an A-line or something to monitor your blood pressures. Frequent neuro checks. Again, at least every hour, if not more frequently, if there's something going on. And we can do the NIHSS scale. And then you want to monitor the procedure site. So wherever the IR docs went in to remove this thrombosis, You want to check the site for bleeding, for bruising, for hematoma. If they're swelling, again, you want to check for the pulses and everything, like we said with the neurovascular assessments. Oh, yeah. Potential nursing problems, these are all things that we can treat with protocols or call the docs, or we're the ones at the bedside that's going to notice kind of what's going on. So intracranial complications would be if their bleed is getting worse or if their symptoms are not improving. Blood pressure and perfusion, again, we have those parameters which we want to keep our blood pressures at. Perfusion is checking for pulses if they had any kind of intervention. Blood glucose, if they're MPO, they're not eating. Are they diabetic? Are they not diabetic? We want to make sure we're checking their blood sugar. I think it's every 6 hours if they're MPO. Aphasia and dysphagia, you guys know the difference?
Yeah.
What's aphasia?
Aphasia is difficulty with your speech, dysphagia is difficulty swallowing.
And then there's receptive and expressive. Different types. So risk to the paralyzed extremity for the patient that has that unilateral weakness. Obviously they can't move it, so you want to check the bony areas such as their elbows or their wrists. Make sure there's no pressure sores under those areas. When you're turning your patient, there's risk of like hurting their shoulders. So you just want to be really careful with those patients. And then depending on how severe it is, it can affect their bowel and bladder function if it's like sensory or motor function. And then DVT prophylaxis. One, because they're hospitalized, but two, now because they can't move as much. You can't get them out of bed, walking around. So within the first 24 hours, we are withholding anything like heparin or Lovenox, but you can still give the compressive pumps on their legs. Other complications from ischemic stroke. Cerebral edema usually will happen, if it's going to happen, within 3 to 5 days after the initial stroke. And it's one of the most common causes of death during the first week after a patient has a stroke. Hemorrhagic conversion is bleeding from an ischemic injury. Again, usually if we've given TPA, this can happen. Seizures are less common with the ischemic stroke, more with the hemorrhagic strokes, just because of the increased intracranial pressure puts you at risk for seizures. And then that's also pointed out here, potential complications from hemorrhagic stroke, seizures. Because of that increased pressure, a lot of times patients will be prophylactically treated with IV Keppra to prevent a seizure from happening. Hydrocephalus is fluid in the brain, hyponatremia, vasospasms, bleeding. So sometimes if the bleed is bad enough, they will put a ventric in the patient. And then sometimes they will do it in the ER, but we try to get them up to the ICU, so that's more important for the ICU nurses in here. What's the normal ICP?
Less than 15.
5 to 15 is normal. Blood pressure and perfusion, again, we want to keep a close eye on their blood pressure so that it's not too high, not too low. It's like I said, it's important to keep it under 185 over 105, but you also don't want to drop it too much because then that's going to affect their perfusion. So you have to ask the doctors what the goal of the blood pressure is. And they'll usually give you parameters. If they're on some kind of drip, it's really important when you're titrating the drips, because if they're not perfused appropriately because you drop the blood pressure too quickly, that can also cause more damage. So make sure you have specific parameters from your physician. Here it is again. Blood pressure is elevated in 40 to 80% of all strokes within the first 1 to 2 days, so you want to manage the blood pressure. Permissive hypertension is saying that it's okay that this patient's blood pressure is a little bit higher than normal as long as it's under that 185 over 105. Avoid hypotension because it can cause changes in perfusion and dehydration as well. Here are the parameters. If you're having an ischemic stroke, it says there's no really benefit to lowering the blood pressure too much. Hemorrhagic stroke, you want to avoid lowering it to. Sorry. Whatever. There's parameters listed here. Basically, ask the physicians what they want your parameters, because again, you don't want the patient's blood pressure to drop too quickly, too soon. These are the medications that we use to treat high blood pressure and stroke. The most common one you'll see is probably the nicardipine drip. Calcium channel blocker is not going to affect the heart rate as much. Labetalol, you usually just give a couple like IV push doses, probably prior to TPA, just to stabilize their blood pressure, so we can give TPA and then kind of monitor from there. Blood glucose monitoring in stroke patients. A lot of times when they come in with altered mental status, it can mimic some symptoms of hypoglycemia. So you always want to check a point of care blood sugar when they're first exhibiting any kind of symptoms of a stroke or when they're first coming in through the ER. Hyperglycemia can affect the penumbra, which is, we said, the area around the stroke where the brain tissue can be saved. A blood sugar greater than 300 can cause issues after TPA administration. And like we said, it also can go too low since these patients are NPO for 24 hours. So just keeping a level normal blood sugar is very important. Speech, we talked about the aphasia and dysphagia, expressive versus receptive. What's expressive aphasia? So they can speak a little bit, but they have difficulty finding words. Whereas what's receptive aphasia? What was that? A hard time understanding others' words. Right. So they're able, so they can totally comprehend it, and they're able to speak, but the words that they're saying don't make sense. So if you say, I don't really have anything. If you ask them what this is and they say it's a cup, then they can't describe it. So that's receptive aphasia. And then a lot of patients, if they're given TPA, can regain their language skills within a year. So sometimes you won't see the TPA effect right away. You won't say, oh, they got TPA, or aren't they looking better? But again, they can improve these deficits up to a year after TPA administration. Swallowing function and dysphagia. Obviously, that we have to do a swallow evaluation on these patients, either before TPA or 24 hours after TPA, NPO, for that 24-hour time frame. They're at an aspiration risk, so you want to keep the head of the bed up. Consult speech therapy. Post-stroke pneumonia occurs in a lot of patients, but it can affect 35% of patients and cause death from the stroke, just a complication from stroke, basically. They can develop during the hospitalization. They're weak. They're not eating a lot. Their muscles are affected from the stroke, so they're not taking in deep breaths. We can't really teach them how to use the incentive spirometer because they're having one-side weakness. The 25 pairs of muscles are not working appropriately, and a lot of times they'll be readmitted for that. If they're readmitted within 30 days, the hospital is responsible for that entire bill. So prevention of the pneumonia, the bedside swallow screen before TPA, or 24 hours after TPA administration. Do you guys all know how to do a swallow screen? Nursing can do that before you consult speech therapy. You can pass somebody. If they do well, you don't have to get speech therapy involved. So there's an observational.
Make sure you do the dysphagia screen. You get reports, and he's always checking those. You give them medicine, you haven't done a dysphagia screen, and you come in for a possible stroke. We're going to hear about it, and you're going to hear about it.
We'll go over documentation. So there's the observational screening. If this patient is just drooling out of their mouth and they can't even maintain their secretions, obviously they're going to fail. You're not going to give them anything to drink, and you're going to consult speech therapy. But if they seem okay, they're kind of talking to you, they kind of seem with it, they're able to maintain their secretions. You can do a water swallow test. So this is the water swallow screening. So give them some water, just in a teaspoon, see how they can maintain and swallow that small amount of liquid. Even if they cough a little tiny bit afterwards, you're going to fail them because they could have aspirated that, even though it's just water. If they can tolerate the teaspoons, then you want to give them a couple sips out of a cup or a straw and just have them take some slow sips and see how they do with that. If they pass, then you just document in your dysphagia screening that they passed. If not, you consult speech therapy. And when you do your flow sheet, if you fail them, it automatically pops up as an order to consult speech therapy. So here it is. If they fail at all, just wait for speech therapy. Don't try to repeat it. When is it not indicated? These, again, are in your flow sheets. What gurgly voice means they can't maintain their own secretions, if they're drooling, if they're having facial numbness, decreased level of consciousness, no cough or gag reflex, their speech is slurred, they can't control their tongue. Again, you can probably tell a lot of these things just by looking or listening to the patient with your assessment. All right, documentation. ER nurses, this is in your little red and green dot assessment. ICU nurses and anyone in between. If you just go to the flow sheets and type in swallow screening, this will come up. And it's just a drop-down menu. So it asks the first question, and depending on if you put yes or no, it'll keep giving you more tabs that you have to fill out. If the patient fails, then this NPO effective now and consult the speech therapy automatically pops up, and just order that as a protocol. You don't have to get any kind of permission from the doctors. And then also document, so it's going to ask you the date and the time that you do it, but you can still put it in your progress note as well. Attempted to perform swallow evaluation on patient fail. Some stroke patients can have cardiac dysrhythmias, which we talked about a lot of slides ago. Depending on the area of the brain where the stroke is, it's more often with a right-sided stroke. Only 4% of them can be lethal, but again, if you kind of can notice that quickly and intervene quickly, you may be able to save them. And then the most common ones are listed here: bradycardia, ventricular ectopy, VTAC, SVT, and AFib. A lot of these patients already have AFib, which puts them at the risk for stroke anyway. But now, if they develop AFib after it, now they have a higher risk to have another stroke or another TIA. So, again, important for future prevention. We talked about the risk to the paralyzed extremity. You can hurt their shoulder if you're turning them, or if they're not moving or appropriately. You can have skin breakdown. You can have change in tone because they can't really move, so they're going to lose a lot of their muscle tone there, and it's just going to kind of become like very weak and flaccid. And then some ways to manage that is just positioning it. Maybe if the arm is like that, you can get the patient a sling. You want to avoid that arm for any kind of IV therapy, unless it's really the only arm that you can use. You can have bladder dysfunction when you have a stroke, again, because of depending on where the stroke was, what nerves it's affecting, what cranial nerves it's affected. So you're either going to have retention or incontinence. It can last up to 6 months. It can be atonic or spastic. If the patient is confused, they might just go to the bathroom. They don't remember that they even have to go. If there's a cognitive difficulty, or if there's like loss of control just from the motor function, or if they can't even feel that their bladder is full, they might just either retain it or they might just keep going. We want to avoid catheters just because of the risk for cauties. If they do have a catheter, you want to make sure that you're performing your Foley care every day or every shift. You want to educate the patient or the family or whoever's going to be taking care of these patients afterwards, Foley care. Texas catheters are great for men because they're not invasive, but they're also protecting their skin. For women, you're just going to have to check them more often. And then when you do your flow sheet for your LDA documenting for your Foley, it asks you every single day kind of why this patient still has this catheter, so it's a daily reminder if you can remove it or not. bowel function, can lead to constipation. Again, just because of some of the nerve function. So you just want to start the patient on a bowel regimen. Or the doctors will start the patient on a bowel regimen. DVT prophylaxis, we talked about avoiding it for the first 24 hours if the patient was given TPA. If it was a patient that was not a candidate for TPA, you can give them Lovenox, you can give them heparin, you can use the Flotrons for their legs, and then they will be discharged usually at least on aspirin. Here we go, like I just said, aspirin. Secondary stroke prevention, if the patient was lucky and they just had a TIA or they had really good outcomes with TPA that we administered, you really want to provide them with a lot of education, the proper like best practices for discharge for medications and their follow-up. So aspirin to thin the blood, statin to help with the cholesterol plaques, and then if they're having AFib or aflutter, some kind of additional anticoagulation if they're a candidate for it to avoid any of these extra clots from forming. And then, like we said, rehab, follow-up for physical therapy just to get their function back. Again, more secondary stroke education prevention for family members, for the community. FAST is the acronym. I don't know if you guys got the little badge, buddy, but there's a little badge thing. We can get them for you if you want them. So the F is for, do I have it on here? Nope. So F is for facial droop. A is for their arms if their bilateral movement is asymmetric. S is for slurred speech, and then T is for time because time is brain tissue. So you want to call 911 right away. Some of that stuff is repetitive. Questions on strokes? It's a ton of information. So you just want to know the two differences, if TPA is indicated, and how you're going to treat your patient after TPA administration, or if they aren't a candidate, how you're going to treat them. Any questions? We good on time? Anybody need a break? There's not many slides left.
15, 30 minutes left.
Oh, okay.
And then we're going to switch it around a little bit.
Okay.
You guys, since you guys are starting to get mine on, instead of showing you the video at 12:30 and running it till 1:30, then sending you lunch break, then the lunch break. Maybe 45 minutes, we'll be back at 1:15.
We won't be 30 minutes unless we have questions at the end. All right, second neuro emergency is seizures. Excuse me. So what is a seizure? Rapid abnormal electrical activity in the brain. Again, just like we talked about with stroke, it's a different kind of injury to the brain, but time is brain tissue, so you want to intervene quickly when you have a patient that's having a seizure. So seizures can be caused for multiple reasons. It can be underlying neurological problems. Sometimes people, they're born with epilepsy and they'll have it for their whole life. It can be caused by some kind of brain tumor, which is increasing the intracranial pressure. Hemorrhage is the same thing. Trauma, infection, they can all increase the intracranial pressure, which can lead to seizure. Drug overdose, drug or alcohol withdrawal, especially alcohol withdrawal, not so much drug, but definitely alcohol withdrawal can cause seizures. So if you know your patient is an alcoholic and they're admitted to the ICU, you're going to be wanting to do these frequent assessments, and there's a flow sheet. I think do we use CWA here? CWA evaluation. Again, they're given a number based on their clinical presentation of how likely they are to have a seizure after from alcohol withdrawal. This is just the path behind what happens when a patient is having a seizure. There's increased metabolic demand, increased blood flow to the brain, anaerobic metabolism, and then secondary ischemia and brain injury. So we try to avoid that by treating either prophylactically or treating quickly. So there are different types of seizures. You guys probably all learned this in nursing school. So again, I'm not going to read it off the slide, but you should know this for the test. The different types of seizures and the symptoms that the patient is presenting with. They're all listed here. There's 2 slides for this. Pretty important. Status epilepticus. I can't even say it. Epilepticus is probably the most serious emergency type of seizure. It can be an issue if it's not treated quickly, because they're literally just seizing for that entire time straight, and it's damaging their brain. So it suggests treating it, if doing some kind of like serious intervention if they don't stop seizing after 5 minutes. Sometimes these patients have to be intubated, they have to be on sedative drips, paralytic drips, just to stop this seizure activity from happening when it's really bad. And then there's convulsive and non-convulsive. So if you think about typically, the two types of seizures that you'll see, convulsive, is when the patient's moving all around. And then non-convulsive is they're kind of just laying there, but they really cannot respond at all. They're breathing on their own, their eyes are open, but their brain is not working appropriately. So the convulsive you can see, the non-convulsive is usually diagnosed with an EEG. So diagnostic testing for seizures. Labs are usually, sometimes patients will have seizures if they're non-compliant with their seizure medication, so you can test the level of the medications that they're on to see if they, if their dose needs to be changed, if we know they're not taking it, how much extra we're going to give them before we discharge them. CAT scan or MRI will show the brain activity, lumbar puncture. EEG is probably the most common one that we'll see because they put the electrodes all over the head and then they get a reading of the electrical activity in the brain. Continuous video monitoring, we don't do that much, but it's just so that you can actually visualize the patient if they are kind of convulsing or not. And then they do some intracranial electrodes. I've never really seen that done here, but they'll actually put them into the brain. This is what's important to us for nursing. You want to control the seizure. You want to keep the patient safe, prevent them from reoccurring, and then identify what's causing the seizure so that you can treat it to prevent this from happening again. So it can be a little scary at first, right? If you've never treated a patient with a seizure, if you've never seen one. So the main thing that we want to do is maintain their safety and their airway. Stay with the patient, roll them on their side. You don't want them to choke or aspirate on their spit. If they're vomiting, you don't want them to aspirate that. Roll them on their side so that it kind of comes out of their mouth. If you have suction set up, get the suction in the room. We're going to pad the side rails, pad the bed. You can order them from SPD. They're not as good as the ones we used to have. Your units might still have the big blue pads that you can use, but now they have these little tiny black wedges to help pad the bed. What'd you say? Yeah, they're tiny, they fall, they move.
Especially when we have 6 foot men that sees all the time.
Yep.
And they're like pads would probably be
They're so tiny.
Yeah.
Yeah. With the big blue ones we used to have were like this long and you can velcro them to the side of the bed. They were much better. But they probably were more expensive. It says do not attempt to restrain the patient from moving. You don't want to tie them to the bed, obviously, like physical restraints. However, you still want to keep your staff safe and you want to keep the patient safe. So you might have to like physically hold them until somebody can give the medication and kind of stop them from their seizure activity. They may need supplemental oxygen. A lot of times you just do the non-rebreather to be safe until you stabilize the patient and see where they're at. You can transition them to room air or nasal cannula. And then, like we said, set up the suction so that you can get anything out of their mouth. Don't place anything in the patient's mouth. Don't stick your fingers in the patient's mouth if you think there's something in there because they could bite down on your finger. Prolonged seizures, like we talked about, if they're really, really bad, if they have to be monitored in the ICU or if they're intubated, you just want to have them on all of the continuous monitors there. Blood glucose and assessment for the seizure. A lot of times after somebody has a seizure, they'll have a post-ictal period. Everyone's a little different. It's usually like about an hour until they really kind of come out of it and they're back to normal. So you just want to assess their breathing, their neuro status. If you can, put these patients where you can see them in the ICU. Obviously, you guys are kind of sitting outside the rooms. In the ER, we try to put them in the hallways so that we can see them or in rooms right in front of us. So nursing management is really just safety and airway management. Different medications that we can give. Benzodiazepines. I don't know the generic names for these things. But, is Dilantin. Valproic acid or Keppra are these two IV form. Continuous infusions. These are like the sedation ones when the patients are super, super sick and we can't get them to stop seizing. We just sedate them and paralyze them basically. Hydration to avoid renal dysfunction. And most common one you'll see for like a sudden onset seizure is IV Ativan. We usually do 2 milligrams of IV Ativan. Inpatient or outpatient, these are the medications that are usually prescribed for seizure control, for prophylaxis to avoid it. Keppra, Dilantin, again, valproic acid, Lamictal. Some people that are really bad will have to have surgery to remove the part of the brain where they've identified where all the seizure activity is occurring. Sometimes they'll do like a partial craniotomy, or they'll actually remove like half of the brain, which can cause complications such as bleeding or infection. And then a vagus nerve stimulator can be implanted as well. There's a lot of research that shows THC from the marijuana plant is really helpful for seizures, but it hasn't totally been approved yet for use. That's it. What questions do you guys have? Anything? Any seizure questions? We kind of sped through that. Go ahead. Sometimes we do, yeah, but not often. Usually we try to give Ativan instead of ketamine just because ketamine can cause a lot of like respiratory depression. But you might see it. A lot of times we use ketamine for people, not necessarily seizure patients, but for behavioral. If we have to, but we try to do Ativan. We usually just use ketamine for like patients that are out of control, that come in through the back door that aren't having seizures. Okay.
So for a TPA patient, you're not doing a swallow eval until 24 hours.
So yeah, so a stroke patient that is getting TPA, you either have to do the swallow evaluation before TPA is given or after 24 hours from it's given. You cannot give it in between that 24-hour period of when the TPA was already administered. And the reason behind that is because even if you just give them, maybe somebody like forgets to do the stroke screen and they're like, oh, you know, they're talking, it looks like they're swallowing okay, and they give them food. If they aspirate on that food, it causes some kind of respiratory distress, and now they have to intubate the patient. There's a huge risk to cause bleeding and trauma during the intubation because we give them TPA. So that's the main reason behind it, keeping patients NPO for 24 hours after TPA. So either do it before or after. However, some patients, like we said, their neuro status changes, their ability to swallow, their ability to speak, it changes. So at any point, even maybe you did the swallow screen and they were fine, and then they change, you can cut them off and make them NPO again. It's your nursing judgment, and it's for the patient safety. Anybody else?